Hi, everyone, and welcome to Acceleration Tools for Predictable Tooth Movement. I'm Dr. Esther Feldman, and I'm coming to you from Los Angeles, California. Just quick two announcements. One, go ahead and feel free to type in any questions you guys might have as I go through the presentation, and I'll address them all at the end. And just in terms of your CE credits, you're going to get an email about an hour following the conclusion of the webinar. It's going to be a short quiz, and so look out for that, and then you will get your credits. All right. So just a couple of slides for me to go through. So this is a disclaimer. I have been compensated in the past for consulting and or evaluating products for the sponsor, including Propel Orthodontics. For my participation in this event, I've received an honorarium from Propel Orthodontics. The opinions expressed in this presentation are my views and may not necessarily reflect the views or policies of the sponsor. The materials provided are for educational use and not to be used for advertising or product endorsement purposes. This presentation has been approved for continuing education credits. No photographs, video, or audio recordings permitted during the presentation. Now the disclosure. I am not employed by any dental company. I do not own stock, securities, or interest in any dental company. A family member, whether immediate or extended, is not employed by or owns any stock, securities, or interest in any dental company. And I have consulted or evaluated products for some organizations, including Propel Orthodontics. All right, so a little bit about me. So I'm originally from Montreal, Quebec, Canada. So I'm perfectly bilingual in English and French. I spent 7 years at McGill University. I got my bachelor's in science in anatomy and cell biology, and then went on to do my DMD, my Doctor of Dental Medicine at McGill. Following McGill, I moved to Vancouver, British Columbia, and went to UBC, where I got my diploma in orthodontics and a master's in craniofacial science. I am double board certified. I have both my ABO and my Royal College, which is the Canadian certification. I started a solo practice in Los Angeles in 2017. And I published an article in the AJODO in 2015, and that was based on my master's thesis from UBC. So a little bit about my practice. It's in an area called Brentwood, Los Angeles, which is West LA. I have 3 chairs and 3 staff. It's a small boutique practice. We are fee for service and out of network with dental plans. So really personalized care is my big focus, and I'm lucky to be in an area of favorable demographics. And what I mean by that is a lot of young professionals, a lot of good private schools. Most of my patients are highly educated and come from affluent backgrounds. So these are my 2 staff, and we're looking for a third right now. Obviously not during quarantine. I'm gonna do that afterwards. And I have some pictures of my famous Invisalign Jello shots that I had during my grand opening, which was a couple years ago. So today we're gonna talk about Propel Orthodontics. My main focus is really gonna be on vibration, so more the VPRO series, but I am gonna touch on the Accelerator series, which is micro-osteoperforations, because I often use the 2 together. So I'm going to start by going through a review of micro-osteoperforations, and then I'll switch over to focus more on vibration. So a little background, we're going to talk about bone remodeling and bone turnover. So we know it's a continuous process. We know that bone metabolism is part of the homeostatic process in the body, where bone is both formed and resorbed, usually at equal rates, although it can be affected by different things. So differs by individuals. It can be affected by different medications, different systemic conditions, and of course, age dependent. So a younger teenager who's going through puberty, the bone deposition and formation might outweigh the resorption versus an older person where it's the opposite. So what we're trying to do with micro-osteoperforations is we're trying to get what we call a regional acceleratory phenomenon. So by just focusing on this particular process, we want to get, by stimulating it and causing a healing process that would last about 4 months, we'll get a faster rate of orthodontic tooth movement. So what MOPs typically do, they target at this level, at the level of the bone metabolism. So when we stimulate the bone, we see an increase in cytokine levels, a temporary decrease in bone density, so more resorption, an increased rate of the remodeling process, and an increased rate of tooth movement by ways of all of those. So just some science, since we all practice evidence-based dentistry. So this was an article that was published in the Journal of Orthodontics, and the conclusion was that MOPs significantly accelerate tooth movement. It's well tolerated by the patients, and it's also a safe procedure. It's considered to be minimally invasive. And what they also saw was that MOPs could reduce orthodontic treatment time by greater than 60%. So again, at the level of bone remodeling, by stimulating the bone, we can change treatment time and make it faster by greater than 60%. So these are the two devices that are part of the series that Propel has to actually do these MOPs. So the manual driver is pretty obsolete. That requires quite a bit of force from your wrist to actually turn it. But the motorized version, which is much more common and I highly recommend, it's really easy to use. It's made out of high-grade surgical steel. There's no risk of it breaking. The tips are disposable, so each patient, each time you use it, you would put it in the sharps container afterwards. You can adjust the RPM, you can adjust the torque. It's really easy to use because the head is quite small. It engages really quickly. You don't have to use a lot of force, and you can also place TADs with the motorized device. Something I also love to tell my patients is that it's FDA approved. People love those keywords. It just gives them a lot more confidence when you're about to do something like drill into their bone. So this is the device I highly recommend, the motorized MOPs. So it is the gold standard, and the nice thing about it is it doesn't matter what appliance you're using, whether it's aligners, whether it's braces. It's at the level of the bone again, so it's really just affecting that bone remodeling, and that's what's going to change your orthodontic tooth movement rate. It's not compliance dependent. It can be done at any time in treatment. So if you're trying to close a difficult space and it's not closing and you're a year into treatment, you can go ahead and use it. Creates more predictable movement. So especially protraction, retraction, certain torque movements, this is going to be your best friend. So you can use it. You also decide, because it's customized, where you're going to place these perforations to, if you want to do it unilaterally, if you want to do it to one tooth, if you want to do the full mouth. It's totally in the control of the doctor. It's considered to be root protective. To me, this is one of the best advantages of doing MOPs. So if a patient's at high risk of root resorption, or if you're doing a movement where you know there's more risk of root resorption, by creating less dense bone temporarily in that area, you're actually protecting the root. You're making it work less hard to get that movement. There's pain reduction because the bone isn't as dense, the tooth doesn't have to work as hard to move. And we'll get to the end much faster and much smoother. So here's what the procedure really looks like. So when the patient comes to my office, I don't do my MOPs at the same appointment as they get their appliance, whether it's brackets or aligners. I want them to adjust to that first, then I'll have them come in, sign their consent form. Then we'll look at the area that we're focusing on, and if it's the whole mouth, I'll palpate between every single root. I'll pull up the Pano or the FMX if I have one. I have the patient rinse with chlorhexidine for 2 minutes, and then I anesthetize. I infiltrate with a needle. So I'll isolate it to the upper arch at first, numb it, and then I'll go ahead and do my MOPs, and then I'll go to the lower arch afterwards. So one thing that I think it's a big misconception with MOPs it's not the actual drilling of the holes that's causing the change. It's the fact that when that tip engages into the bone, it creates so much stress that it radiates these little microfractures. And it's those microfractures through the cortical bone that elicit that healing cascade that really is what speeds up the tooth movement. So what we're doing is we're actually changing bone chemistry when that tip engages the bone. So here are some other little facts about MOPs. So it's totally regional. So when you tell patients what you're doing, you want to make sure that they understand that that pro-inflammatory environment that we're creating with MOPs is really limited to where we're doing it. So it's the mouth. That's it. It's not going to extend anywhere else. The more the merrier. So usually it's 1 to 3 MOPs per site. You do them vertically or kind of in a triangular formation because that rate of remodeling is going to be proportional to how many you do. And the depth is pretty shallow. It's usually just through the cortical bone. I would say not more than 3 millimeters deep. When you feel your tip, it's really, you'll feel it, the tip engaging the bone. You can feel that you're at the point that you need to be. So in my office with my adult population, I really present this to about 80% of them. The first question most of them have, even before how much is it going to cost, is how long is it going to take? So doing something like MOPs is huge because it reduces the treatment time so significantly. So as long as they're not overly anxious or another contraindication, which would be pregnancy, I would present this to most of the patients. So again, it's really important to set expectations. We don't want patients to come in thinking that they're not getting numbed or that they're not going to feel anything at all, because as an orthodontist, this is the most invasive, I would say, I get. So I compare it to acupuncture in the mouth. I tell them that that's really what I'm doing. It's going to be a bunch of little needles to numb them up, and then they don't feel anything after that. By the time I'm on the lower arch, the upper arch is oftentimes denumbing. So I'm not using a lot. I'm using about half a carpule per arch. So I also tell them it's less numbing than they would normally get for one filling. And then another thing is sometimes the MOPs need to be repeated. So if I'm doing a full mouth, it's really rare that I'll do a full mouth ever again, but sometimes there's 1 or 2 teeth that just aren't complying with the movement. So we'll redo those teeth 4 or 4.5 months later. So I really like to emphasize the important things, that it's minimally invasive, that it's FDA approved. They will be in some discomfort because it is a lot of infiltration, so minor discomfort. That treatment's going to be 60 to 70% faster if they wear their aligners or come in for their visits for their wire changes. And with aligners, I like to stress that they'll start with 3-day changes immediately after the MOPs procedure, as opposed to whatever other cycle you would normally be on. So a couple of catchphrases that I use. So I treated both my husband and my mom with MOPs. And I love those people very much. So that usually instills a lot of confidence in my patients. Again, I like to stress that it's a lot less anesthetic than one filling. The fact that there's no downtime. So when they leave the office, I give them 2 extra strength Tylenol, and I tell them that as soon as the numbing wears off, they can go ahead and eat, so they don't miss a meal. Tylenol is more than enough for any temporary soreness, and I always do care calls the night of just to check in on my patients. Oftentimes, by the time they leave the office, they're not even bleeding anymore. I stress that it's more predictable and more seamless treatment. And then again, if they're with aligners, I like to stress that their interval is much quicker. So this is a time-lapse video, so it's going very quickly, but this is one of my patients, and you can see I'm topping up in the middle just because he was feeling it a little bit. And the most important thing for me is that the patients are comfortable during the procedure. So he was totally fine. It went really smooth. I would say to do the full mouth typically takes me anywhere from 30 to 35 minutes. It's really quick and it's not bloody. My assistant is dabbing at the sites as we go. So this is what it looks like about 30 minutes post-procedure. So if you look really carefully at those little arrows, you can see the little perforations. They're tiny. So it's nice to also show patients, again, when gauging their expectations, that this is what it can look like. So in terms of post-treatment, I always stress not to use any NSAIDs. We don't want to negate the pro-inflammatory environment that we've created. I'll tell them that they will be a little bit sore, a little tender for the next 24 to 48 hours. That's totally normal, but nothing that Tylenol can't fix. So again, just, there's a little card that I give them that just reminds them to stay away from any NSAIDs, Advil, Aleve, Motrin, anything like that. So just a quick case to highlight the power of MOPs. So this is one of my patients. She presented with severe crowding on the upper arch, mild crowding on the lower arch. She's class 2 on both sides, and a deep bite and a midline deviation as well. So when looking at her records, so here's her PAN and her Ceph. So if you focus on the PAN and you look at the upper sixes, especially on the upper left, you can sort of see there's a periapical lesion on the mesial root on that upper left six. Both of those crowns didn't look good. Both of those endos didn't look good. So when I decided that I was going to extract on the upper arch to help with the severe crowding and to be able to retract her canines into class 1, I actually opted to extract her upper sixes because I wanted to leave her with a better oral health situation and not leave questionable teeth in her mouth, even though taking out premolars would have been much easier for me from a mechanic standpoint. I decided that I could close a 12mm space on either side. So again, poor prognosis on the root canal treated crowns on her upper sixes. That work had been completed back in Russia a while ago. So we decided to extract the upper sixes, and she was treated with braces. So this is her at 16 months into treatment. So I have closed quite a bit. She does have a tad on the upper right side to help me retract that canine, but she was starting to burn out. And I had warned her that it was probably going to be about 30 months to get, I told her 30 to 36 months potentially to close that 12mm space. And she was wanting me to speed things up. So I told her about Propel. So I did selective Propel for her. So I really just did my MOPs in these extraction sites at 16 months into treatment. And this is my favorite slide because you can see that her tissue could not keep up with the tooth movement. So I actually had bunching of tissue between the premolar and the 7 because the tooth was moving so quickly. So I actually had to send her back to the periodontist to excise that tissue because it was creating a physical obstruction to finish closing that space. And here she is at 22 months. Space is closed. So for a patient like this, Propel is huge, and it's a practice builder because when you do your MOPs and you're able to close space so much quicker, you have a happy patient and a great referral source. And this is her at her first retainer check. So she came in and you can see it's quite a dramatic change and she's thrilled. So I find that when I do it, most of my patients are a little nervous when they come in, but oftentimes by the time they're done, they say, that was it, that's it, that was nothing. Not very painful, a bit of a weird feeling, and most of them will all agree that the numbing is the only negative part because it is so many infiltrations. And it's always worth it. I haven't had any patient regret it. And I've had patients calling my office because of this procedure, because of patient reactions. So now we're going to switch gears. And again, the main focus is going to be vibration, but some of the cases I'm going to show you will have both vibration and MOPs. So I'll be sure to let you know which ones those are. So this is obviously a lion. I was on an African safari this past summer, and look at those teeth. Amazing teeth. This is me and my husband with that lion behind us. And during a time like this, when we're stuck inside, this is the Maldives. I highly, highly recommend if you guys can make it out to the Maldives to go. And now we're going to switch gears and talk about high frequency vibration. So some of the benefits of high frequency vibration. So pain is reduced, and that's by means of the vibration creating more blood flow within the gums and the bone. Improved aligner seating, reduced refinements, treatment time reduced, root resorption reduced, an increase in bone remodeling, and retention bone density increase. And I'm going to show you support based on the literature for each of these benefits. This device is also FDA approved, and the best part about it is that you only need to use it for 5 minutes a day. 5 minutes is nothing. So when you tell patients about this device, it often sells itself. In my office, I sell it as an adjunct. It's not included in treatment. So some of the science behind vibration. So vibration and bone density have been studied for a really long time. So that started back at NASA, where they were studying it. Historical and ongoing research demonstrates that bone cells are more responsive to higher frequencies versus lower frequencies. So with the VPRO series, the nice thing is it's a high frequency vibration, and that's really what we're going to focus on in the literature as well. So the clinical benefits are divided into two categories, physical and biological. And I'm going to go through each of these benefits again, which are supported by the literature. So some recently published human trials that confirm the preclinical research. So the first one, so this looked at efficacy of high frequency vibration versus low frequency vibration on different cell types that are found in the PDL. So included osteoblasts, fibroblasts, and osteoclasts. And what they found was the higher frequency vibration significantly had greater cell expression and cellular proliferation of these cells. So it was way more effective. The second study looked at specifically tooth length and high frequency vibration effect. So it was really looking at root resorption. And what they found was, again, higher frequency vibration had greater root preservation. So they were seeing less root resorption on patients that used higher frequency vibration versus lower frequency vibration. And finally, the last one, which specifically looked at the effects of high frequency vibration on clear aligner therapy. They found that high frequency vibration showed significantly improved aligner tracking and less refinements as a result of that. So this study, which was the first one, so what it was, so they took, this one was looking at cell responses, those three different cell types. So osteoblasts, fibroblasts, and osteoclasts. So they had cell culture plates that were attached to different devices. On the left, it's the low frequency device, and on the right is the VPRO series, the high frequency device. And what they found was that the peak accelerations from the high frequency were 70% greater than those by the low frequency devices. So it was quite a difference. The greater vibration frequency and peak accelerations of the VPRO coincided with greater cell proliferation and gene expression in those cell types in the PDL. And finally, they decided that it was a striking difference. Now, this article talks about the paradox, the anabolic and catabolic effects of high frequency vibration. And this was a landmark study because it really looks at the dual mechanism of action, which depends on the phase of treatment. So the phases of treatment are divided into the active phase and the retention phase, or the non-active phase. So one has force and one doesn't have force. So the catabolic, the breaking down, which are, these are the two sides of the bony metabolism that we looked at the very beginning when I was talking about MOPs. So during active treatment, it's more focused on the catabolic phase of bone remodeling. And in the retention phase, when there's no force, it's focused more on the anabolic, on building of bone. So in this figure, you can see that, so this is looking at orthodontic tooth movement, and it's comparing low frequency and high frequency vibration. So the high frequency vibration was statistically significant more orthodontic tooth movement. And that's as a result of favoring the catabolic side of bone metabolism. And then if you look at the right side here, the retention side, so focusing more on the anabolic, the building back up, the increase in bone density, you can see that the high frequency vibration again was statistically significant. So quite a dramatic difference between low frequency and high frequency. So back to this figure again, just to reiterate and re-emphasize. So high frequency vibration has two different mechanisms of action. So with force, with orthodontic force, it's going to favor the catabolic side. It's going to favor resorption. It's going to help tooth movement happen faster with less root resorption and less negative effects, versus in retention, where the high frequency vibration is going to accelerate bone deposition and increase bone density. I especially love to tell my middle-aged and older female patients about this, because we know with postmenopausal effects, bone density becomes a big issue in calcium metabolism, especially for women. So just letting them know that this investment that they're putting in at the beginning of treatment is going to be able to be used and helpful and beneficial to them in the long term, I find is something really nice. It's an additional bonus when you tell a patient about it. So this is just an example from Dr. Shipley of how the VPRO can help with retention. And this also has to do with, again, being an aligner seeder. So this is a patient who presented to his office a year into retention, and they had relapsed because they weren't wearing their Vivera aligner. So specifically, if you look at that lower left one and lower right one, that retainer wasn't fitting well. And the patient was complaining that it was difficult and painful to put the retainer in because it wasn't seating all the way. So obviously the parents don't want to pay for retreatment, and they also had a second child who was due for treatment. So what Dr. Shipley did was he had the patient put the VPRO in for while in the office for 5 minutes, and immediately the patient was able to tolerate it and the aligner was able to seat better. So by pushing the patient to continue to use that VPRO to seat the retainer, they recaptured the alignment of those teeth. The patient was happy, the parents were happy, gained a referral, and the second child started treatment. So again, improved bone quality at retention, so the anabolic side of that paradox. So the results have demonstrated subjects using high frequency vibration have a statistically significant net increase in bone density at the completion of active orthodontic treatment. So really emphasize that this VPRO can be used forever. So I like to tell patients in retention, for the first 6 months, they should continue using it every day. But if they want to use it once a week after that, it's just something that's going to help them. Most of them love it. They find once they're so used to it and it's part of their routine, they find it to be soothing. So it's never been an issue to tell a patient to continue to use their VPRO. So a review of the benefits, because there are so many. So reduced pain, aligner seating is improved, so both in active treatment and retention. Less refinements. Treatment time is reduced because of the better tracking. Reduced root resorption on the catabolic side of that curve that we looked at. Increased bone remodeling after treatment, and retention bone density increased as well. And it's such an easy little device, and it comes in that cute little case now, really user-friendly. So with just 5 minutes a day, and again, I love to emphasize the 5 minutes a day because 5 minutes is nothing and it's self-timed, they're going to get improved accuracy. They get to change their aligners more frequently, the reduced pain and discomfort, and the increased bone remodeling marker. So all of these benefits. So just stressing benefits to patients, this device is such a home run. So who's a candidate for high frequency vibration? Every single patient going through orthodontic treatment. So the only contraindication is vertigo. I've had 1 or 2 patients over the years that have had vertigo and they still had wanted to try it. It was really day dependent if it was acting up or not, if they were going to use it. So just keep that in mind, just a little question to ask them before you sell it to them, so you can, again, gauge their expectations and make sure that the patients know that, it's gonna shake their head a little bit, and if they're very sensitive, you don't wanna exacerbate that problem. So high frequency vibration and braces still has all those benefits, again, at the cellular level. So increasing the gene expression and proliferation of the osteoblasts, osteoclasts, and the fibroblasts. But common problems with braces in particular are pain, slow movement, and binding or friction of the wire with the brackets. So just by means of that vibration, it can help a lot with the discomfort and then the progress of treatment by reducing that binding. And I have a lot of my teenage patients, because it comes with a USB as well, the moms will tell me that they plug it in the car and they use it on the way to school and the way home from school, because they find that feeling of that vibration, and again, getting all the blood to move. It helps them, it makes them feel more comfortable, and they like it. So if a patient wants to use it for more than 5 minutes a day, that's great. I also will compare it to like those power plates that are popular at the gym. So something that's vibrating, that's getting all the muscles recruited and getting everything to move, just to help patients understand really what it's doing. But when you stress that at the cellular level, it's making changes as well. I mean, it's just all around totally conservative, non-invasive at all, and a really easy appliance that's going to make treatment smoother. So in my office, I would say about 99% of my patients in clear aligners purchase the V-Pro. I would say it's less than that for braces, but I still have quite a few that like it, especially the teenagers, because they're very sensitive. I emphasize all of the benefits, that it's FDA approved, that it improves tracking, that the comfort and reduced pain, and that the aligners will fit better. So some of the catchphrases with the V-Pro, like I said, it's non-invasive, totally conservative, has a soothing effect. It changes the biology of tooth movement. It can be used more than once a day. It's self-timed for 5 minutes, and if they want to use it multiple times, that's fine. Creates really like smoother, more predictable treatment. They get to change their aligners more frequently, more efficient, more efficacious, less appointments, less refinements, so many benefits. There's really no negatives to this device. So now we'll look at some clinical cases. I'm going to review a crowding case, a deep bite, a case of collapsed arches, protraction case, crossbite, and open bite. And I'll tell you guys when I used, these are all V-Pro cases, and some of them I used in conjunction with MOPs. So this patient is a 49-year-old healthy male. He presented to my office, chief complaint of lower crowding. And obviously it's that lower left one that's totally bucco version. So he wanted to be treated with clear aligners. And we went with the V-Pro. So here's his pano. Roots look good, nothing weird. And here he is at 6 months into refinement. So at 6-month refinement. So at 6 months, that tooth has already moved quite a bit into the arch. We haven't had any tracking issues. Obviously was a compliant patient, but we got a really dramatic change in 6 months because he was using the V-Pro and wearing his aligners. And here he is at 9 months. We still have a little more settling to do. And here he is, his 11-month finish. So you can see that lower left one is totally aligned. It's in the arch. We have a really happy patient. And this case, which probably would have taken me closer to 16 or 18 months, was finished much quicker because we had this adjunct. So in less than a year with 2 refinements, we resolved that severe crowding on the lower arch. So here's a 13-and-a-half-year-old female, and she presents with a deep bite. And she is an active jiu-jitsu practitioner and fighter. So her mom was adamant about treating her with clear aligners because she has to wear a thick mouth guard when she's at a competition. So treated her with clear aligners and a V-Pro. So here are her records. Nothing untoward. And here she is at 7 months, and we're going to start her first refinement. So she was class 1 mild. Sorry, I'm going to go back. She was class 1 mild crowding. She's not biting properly on that lower right buccal shot. But the biggest thing for me was really just rounding out her arches and resolving that deep bite. Not a very complicated case. So here she is, really good progress. Also loves her V-Pro. This was the mom that told me she has it in the car with her and uses it in the morning on the way to school, in the afternoon on her way to practice. And this is her, 10 months, finished her case. So really nice rounded arches. We opened up her bite. Patient's happy. You could see her smiley face stickers that she came to the office in. But again, the V-Pro is just something so nice that makes treatment go by so much faster. It also, the patients are happy when they use it. I find it's such an easy device to sell. Okay, this is a case where I used both MOPs and the V-Pro. So 60-year-old male presents to my office. You can see how collapsed his arches are. He's really narrow. He's not in Crossbite though. Sorry for the blurry picture on the lower left. He's class 1 on both sides, but with a Div 2 appearance. Moderate to severe crowding on the lower arch. I would say more moderate crowding on the upper arch, but he's got these wavy shaped arches and very square arches that really need a lot of change. And you can see he's got wide buccal corridors on his smiling photo. So again, we opted to treat him with aligners and the V-Pro, but I elected to, when I presented Propel to him to do MOPs, he was totally on board, and I decided to do full mouth MOPs for him. There's his pano. So we did have some difficult movements, especially that lower right canine and the upper right canine. A lot of torque, especially on the upper incisors, focusing on the arch development. So just by expanding him, getting rid of that Div 2 appearance. And he was totally, I mean, he was a really easy patient. He wanted to finish as fast as possible, and I wanted to be able to control my mechanics. So torque with aligners is more difficult. So I knew that doing MOPs would help me a lot. So here he is. This was at 85 days. So it was less than 3 months of progress. And this is such a big change compared to how he came in. So already starting to see on the upper arch that it's rounding out. That lower right canine, which I knew was going to be really difficult, it has moved, but it wasn't tracking that well. So we did elect to re-propel that tooth. But looking here, you can see the change in 85 days. So quite a dramatic change. Patient came in. This is like the first time I saw him after doing the MOPs, and he was thrilled already. He was seeing a difference in his smile. So we re-propelled that lower right canine, and he drinks a lot of tea, so don't mind all this staining, but we're getting a lot of change already. And this is at 13 months, and this is at his finish. So you could see we really rounded out the arches. That lower right canine is in alignment now. The torque on his upper incisors is way better. His upper laterals have come in the way they're supposed to. That's not a great smiling photo, but his smile looks way better now. All right, this case. So this is a case where I'm going to focus on the protraction aspect, even though he's got a lot of other issues. So a 32-year-old male, he's also got funky shaped arches, so lots of crowding, more square shaped. He's an English guy, and he was actually referred to me by the oral surgeon because, I'll show you, If you look at his pan at the upper right 7, that tooth had a hopeless prognosis. So the oral surgeon extracted the upper right 7, and the upper right 6 also didn't look great. And he said to me, I don't want to take out the 8 if we can save it. So let's try to protract the 8 and hope for the best. And I said, okay, let's do it. But I told the patient when he came in, again, closing a 12mm space, I was going to want to do MOPs in that area. And he was totally cool with it. So again, patient wanted clear aligner therapy. Most 30-year-olds don't want to have braces. The upper right 7 was extracted by OS, and the goal was to close the space by protracting that upper right 8. At the same time, we're going to unravel the crowding, we are going to develop the arches and round them out and reduce the deep overbite and fix the torque of those front teeth. So here he is at 2 months, and you can already see that upper right 8 is starting to come forward. And the nice thing about having an extraction space when you're going to do MOPs is that you can go to town. So I probably did like 6 or 7 different MOPs between the 6 and the 8. And you don't have to worry about any roots or anything like that. And you see so much tooth movement there, which is great. So I also had a lot of attachments on that 8. I wanted to make sure that my aligners were going to grab on both buccal and palatally to that tooth to be able to bring it forward. So at 2 months already, we're seeing a lot of change. We still have a lot of unraveling to do on the lower, and that lower left 3 is going to be a tough tooth. And that's the space that's already starting to close. And of course, he's using his V-Pro every day, I think twice a day. And here he is at 3 months. And look how much that tooth has moved in 3 months, that upper left 8. It's really come forward a lot. And the lower is starting to look a lot better, as is his smile. And here he is at 6 months. At 6 months, I had about 2mm of space on the upper right. So huge, huge, huge change there. And I had a really happy patient. He thought he was done. He thought he was done at this point. Lower left 3 still has a ways to go because that root is still quite kicked out mesially. And I'm pretty sure I re-propelled that upper right area and the lower left canine. And here he is at 14 months. So this is where we finished. So he's solid class 1 on both sides. We really rounded out those arches. And I have a little fixed retainer there from the 8 to the 6. It's hard to see from here, but you can sort of see it in the center biting photo. But we closed the space, had a nice contact there. Patient's happy, oral surgeon's happy, GP is happy. And here you could see the difference in 14 months. This case would have taken me probably closer to 2 years without any adjuncts. So again, this is a really good example of selective areas for MOPs and using the V-Pro. So the patient, especially if you look at the upper right 2 in his beginning photo, that lateral is the torque is quite off. I had the patient even bite on the V-Pro just on that tooth for 5 minutes after doing the whole bite for 5 minutes. Just to really engage it, make sure that the aligner was grabbing onto it, because laterals, especially smaller laterals, are really hard to grab in aligners. So the V-Pro is always good for stuff like that as well. I'll always try to tell patients to really force the teeth that might not touch it when they're biting their whole mouth on it. So here's another great case. So this is a 36-year-old male. He was a very busy architect. He travels all over the world, and he came in with a crossbite complaint. So his right side, you can see from 4, 5, and 6 are in crossbite. A lot of crowding, wide buccal corridors. Wasn't happy with his smile. Told me right away he's only doing clear aligners. And I told him, okay, well, you're going to need a V-Pro. So he got a V-Pro. And we did Propel for him as well. he wanted to be done as soon as possible. So I did full mouth Propel for him as well, which was really important. Hold on, I'm gonna go back. If you look at that right side, that crossbite, I wanted to make sure that when I was expanding out the arches with aligners, that I didn't get too much buccal torque on those teeth as a result of the expansion. So I knew that the Propel would help me a lot with, the MOPs would help me a lot in terms of expansion with translating those teeth laterally. So here we are, 4 months into treatment. Again, a really good compliant patient, used his VPRO every day. We did MOPs, and he was pretty much out of Crossbite already at 4 months, and just tons of change. So really happy patient, looks really good already at 4 months. And here he is at 8 months. So we were still doing a little more expansion, but I got a really good translation of that upper right side. I didn't increase that curve of Wilson. I didn't get buccal flaring of those upper right teeth. And I really attribute that to both the MOPs and using the VPRO, knowing that my aligner, knowing that my plastic was totally covering those teeth and hugging them the way it was supposed to, so that the teeth couldn't move away from the aligners when the force was delivered. And I think we're just doing elastics now for some settling at the end. Yeah, and here he is, 10 months, finished his case. So good alignment, good rounding out of the arches, really nice change. He's been a great referral for my office, this patient, because he finished so quickly. His result is great. And he says it was a painless experience. So these are the patients we all want in our office. So here's, again, like looking at the top, the change. So the arch development and that translation in terms of the expansion and not getting any buccal flaring of the teeth. Sorry, you could see some of the occlusal marks. I made sure that we had a good bite at the end. So here's my open bite case that I wanted to show you guys. So this is a 31-year-old male. He had been treated previously as a teenager, and he presented to the office like this and complaining that he wants to be able to eat pizza again, and he noticed that he can't bite with his front teeth, that it was getting worse with time. He had a fixed retainer on the lower. He's class 2-ish on the left. He's class 1 on the right. And he definitely was tongue thrusting when he was here, but I don't know if that was a result of the open bite or if that was what caused the open bite. So talk to him about the VPRO. So for open bite cases, super important. If they want aligners to treat the open bite, they need a VPRO. And I'm going to show you why, especially because he has small lateral incisors as well. It didn't bother him, the Bolton discrepancy, so we elected to do IPR on the lower for him, and that was going to help me with my bite closing mechanics anyways. But those laterals, in order to close them down, he was biting on the VPRO 5 minutes each just on those teeth. So again, rotating the VPRO so that he was just touching on those laterals one at a time to really engage them into the aligners. So these are his records. So it's not a skeletal open bite. It's really a dental open bite. So it's good with treating him with aligners. Took out that fixed retainer, obviously. And here he is at 3 months. So at 3 months, he comes into my office, and this is an example of a perfectly compliant patient. And I got to say, the men in my office, from my experience, have been way better than the women with their compliance. But he's come such a long way in 3 months. So changing weekly with his aligners because of being perfect compliance, wearing his rubber bands, and using his VPRO. So again, he was probably using his VPRO like 20 minutes a day because I had him biting on specific teeth for 5 minutes at a time, plus the full mouth bite for 5 minutes at a time. And here he is at 7 months. So at 7 months, we've closed that open bite. Those laterals have come a long way. We never lost track of them. Bite's looking really good. And here he is at 9 months. So this is him at 9 months at finish. Laterals tracked perfectly the whole time, which is always, a big concern of mine, especially when I have a small lateral. I did have big attachments on those teeth. I actually had both labial and palatal attachments on all 4 incisors, just to really help me control the extrusion, to give him a nicer smile line. And look at his smile. I mean, he's thrilled. And to close a 4 millimeter open bite in 9 months with aligners, I mean, that's the power of the VPRO right there. I would not have been able to do it without it. So here he is at the start, and that's his finish. So huge change, really quick. And again, compliance is huge, but using that VPRO and getting him to use it the way it needed to be used for this case was really helpful. So just to reiterate the benefits of high frequency vibration. So again, combining MOPs with the VPRO is, for me, it was maximum control, predictability, compliance, and profitability. Again, these are adjunctive procedures, so they are a separate fee from the treatment fee. So it's an optional add-on for patients. I do bundle them together, but patients can choose one or the other or whatever they want. 5 minutes a day with the VPRO, that is, totally dependent on the patient at home for compliance. MOPs is totally doctor controlled, so that's something that we can do in the office that we know that we've done, and we'll document exactly where we did it, and we'll be able to look out for those teeth. And that's it. Thank you everyone for your attention, and now I'm gonna check to see if there are any questions. So somebody asked if I do any MOPs on the palatal. I do not. I have never done any MOPs on the palatal. There's really no need. So the answer to that question is no. How much do I charge for VPRO and MOPs? So I charge $550 for the VPRO, and MOPs for the full mouth is $1,200. I usually do about $400 a quadrant otherwise, if we're doing it by quadrant. I bundle them together for $1,500. And this doctor, do I file to insurance? I submit claims to insurance companies, but I'm out of network. So I will have my front office check the patient if they have benefits. So the nice thing about MOPs is that it doesn't fall under orthodontics. The CDT code is actually, it's alveoloplasty. So it actually takes out of their general benefits. So most patients do get coverage for MOPs. VPRO, there's no benefit for that. There's no code for an adjunctive accelerating device. Do I usually convince them to go for this at consultation? So at consultation, which I will present these options to the patient, again, I will gauge the patient. So it totally depends. If it's an anxious patient, I will not present MOPs. If it's a healthy patient who's really focused on time, I will present MOPs to them at consultation. Everyone gets presented with the VPRO at consultation. And MOPs, typically, I don't think I mentioned this, I don't present it to any teenagers. Usually it's like 25 years old and older. So again, because at the level of the bony metabolism, as we get older, the changes in the bone, it's just a little bit harder to move the teeth. So MOPs I typically do in the older population. Do I always do 3 days with either one, VPRO or MOPs? No. So totally different aligner schedule for both of them. So with VPRO, my patients go on 7-day changes usually. When they're in refinement, depending on the case and the movements I'm trying to achieve, I might reduce them to 5 days. With MOPs, the way my schedule works is immediately following MOPs with aligners, I'll have them change every 3 days for 6 weeks. Then it's every 4 days for the following 6 weeks, and then it's every 5 days moving forward from there. So in general, my MOPs cases with aligners, almost, I think 100% of the time that they have the V-Pro as well. So I'm fairly confident on 5-day changes at that point. And again, if there are any teeth that aren't moving and tracking the way I want them to, I might do MOPs again 4 months down the line, once that first effect has worn off on specific teeth, just to help move it along. Have I ever started V-Pro on patients halfway into treatment to help with acceleration? Generally, no. Most of my patients will go ahead and buy that V-Pro at that initial visit when they get their attachments on. But if somebody wanted it, a couple of aligners into treatment, there's no problem with that. Again, that new study showing that paradox that we get that extra bone, that increase in bone density in retention, it's something that it's such a nice bonus that patients will see the benefit in the long run. So getting it partway through treatment is totally fine. When do you start vibration versus MOPs on a case when you're doing both? So vibration is usually from the get-go. So let's say it's an aligner case. So the patient comes to my office, I place the attachments, they get their V-Pro that day. Then I usually have them come back about a week later. So I want them to I don't want to overwhelm them. I want them to get used to their aligners. So I schedule them about a week out to come in for MOPs. The other thing with doing everything at once is it's a really long appointment for patients to get all their attachments placed and do MOPs. And then I don't want them bleeding into their aligners on day one. So I bring them back a week later, then I'll do the MOPs, then they'll start their 3-day changes. Do I have any recommended videos to show it to patients? So I have that time-lapse video that I showed you. The patient is smiling the whole time. That was not staged. I can show that to patients. I often will show them, I have a bunch of pictures from when I did it to my husband and when I did it to my mom. My dad assisted me when I did it on my 62-year-old mom, and it was so smooth and so easy. So when I tell patients about that and I show them pictures of that, if some of them are on the fence, that's usually what's going to push them right over the fence. In terms of how you can order, I don't know if you're referring to V-Pro or MOPs, I would say contact your local Propel rep for that. They're very helpful. I tried upper attachments on the lingual? I have. And this question, yeah, absolutely. I place a lot of my attachments on the lingual, but for open bite cases, I often, especially like the one I showed, I want as much surface area as possible for my aligners to grab over. So I actually do both labial and lingual. For, I would say, the majority of my adult patients, if they're not open bite, I always do upper 2-2 on the lingual without anything on the buccal, because aesthetics are everything. This question, V-Pro first, then put on aligners? No. You use, the whole point of the V-Pro is when the aligners are in. You want that active force on the teeth, then you want them to bite on the V-Pro, because the V-Pro is seating the aligners. That's one of that's the mechanical benefit. The physical vibration of the V-Pro is putting pressure on the teeth to seat the aligners on, to get them to grab over those convex attachments. So aligners in, then V-Pro. And I always have them do it in the office. So I take out the V-Pro, I'll charge it for them, knowing that they're gonna, or I have one that's charged and I'll just put that on their little biting device so that they can use it in the office, so that they know how to use it properly. I think that demonstrating it to them, making sure that they're using it to their benefit, to their maximum, is really important. Do I use V-Pro in the retention phase? Yes. So I always tell patients those first 6 months, especially if they're so used to using the V-Pro at night. And like I said, if they've been in treatment for 10 months, a year and a half, whatever it is, they're so used to it, it's part of their routine. I typically use Vivera retainers for my retention. So using the V-Pro is just part of their regular routine. And I just like the idea of knowing, especially because Viveras are stiffer and thicker plastic, that they're being seated all the way down, and that every tooth is getting a little bit of TLC from that V-Pro to seat into the plastic. Any evidence for VPRO with fixed braces? So all the evidence that I showed you from all of those articles is applicable to fixed orthodontics. The only benefit with aligners versus braces is that the VPRO is like it's physically seating the aligners on. But at the biological level, when it's affecting any of the cells, whether it's the osteoblasts, the fibroblasts, the osteoclasts, that's happening with braces or with aligners. That doesn't make a difference. Do I always place a fixed retainer in extraction cases? So the two extraction cases I showed you happen to have been molar extraction cases. And because I closed those spaces so quickly with the help of MOPs and the VPRO, I really felt uncomfortable leaving those patients without a fixed retainer in those cases. And since they're back teeth that didn't bother the patients, I used a fixed retainer with a Vivera over it. So that's important to me, just to maintain it, just while that bone is still remodeling, because it's been such a big change and such a quick change. If it comes off in a couple years and the patient comes in and it's bothering them, then I'll take it off. But I definitely want to keep it there for at least the first 6 months. Any fit issues with ceramic braces and the VPRO fitting over it? No. The VPRO doesn't actually touch the brackets. The VPRO is more something that the incisal edges and the occlusal surface of the teeth are biting on. So because that's what you're touching, it shouldn't have any effect, whether it's ceramic or metal or whatever you're gold, whatever you're using, because ultimately it's just engaging that incisal edge or occlusal surface of the teeth. So that's really the way it works. It doesn't fold over, so it shouldn't be engaging the brackets. How would I charge for an Invisalign case, like the interior open bite case? So my fees in my practice, and I think it's really going to depend again on the demographics and what area you're in. So I don't charge less because it's going to be a shorter case, because they're getting a VPRO or MOPs or whatever the patient is adding on. So the way I structure the fees at my office is it's really case difficulty and case length. So, it's really between $7,000 and $9,000, let's say, per case, depending on the difficulty. And then I will add on, that $1,200 for MOPs if we're doing full mouth, or $1,500 if they're bundling MOPs and a VPRO. So that's typically what I do. But I don't nickel and dime my patients. So I don't charge them, for broken brackets or broken attachments, stuff like that. Some people do. And let's see. Can I elaborate on whole mouth MOPs? How to? So when I spoke about the procedure for MOPs, so I have the patient come in, again, if they got aligners, a week after I place their attachments. Then when they come in, I will look at their pan or their full mouth series or whatever x-rays I have beforehand. I'll have it up at that op. The patient will rinse with chlorhexidine for 2 minutes. Then I'll infiltrate. First I'll use topical, and I usually start on the upper arch. So if I'm doing the full mouth, I'll put topical all along the upper arch. Then I'll start infiltrating. So if I start on the upper right, I'm infiltrating between all the roots of the teeth. So 7 to 7. And then in the back, so posterior, I typically do 2 to 3 perforations, either in like a vertical line or kind of in a triangle formation. So again, you just want to make sure you're not going near the roots, about 3 millimeters in depth. And with the motorized Propel device, it's so easy and it's so quick. So there are 2 little buttons to go forward and to reverse out. So again, like 10 seconds per MOP. And I just kind of walk my way along the arch. When I get to the anteriors, where there's typically less room between the roots, and the tissue's thinner and the bone is thinner, I might do 1 or 2 MOPs. Totally depends. Canines are big teeth with big conical roots, so I try to give them at least 2, especially if I have a lot of movement or torque to do with the canines. And once I'm done with the upper, I'll already have my assistant prepare the topical for the lower arch, and then I do the exact same thing on the lower arch. And that's it. Well, thank you guys. My email is up. If anyone has any questions, feel free to reach out. I really appreciate your attention. I know you guys are so busy during this time where we're all stuck at home. And I hope to meet you all in the future. Thank you.